Hi, everyone. Welcome back to our next episode of ReWalk's Topics in Neurorehabilitation webcast. I'm Jill Butler, and today we'll be talking with Dr. Christopher Cirnigliaro. Dr. Cirnigliaro is the Research Laboratory Manager and Bone Densitometry Technician at the James J. Peters VA Medical Center for the Medical Consequences of SCI. He is a clinical exercise physiologist and certified bone densitometry technician with expertise in DEXA analysis. His research investigates prevention and reversal of bone and muscle loss after SCI, including clinical trials of bisphosphates and denosumab, and extensive cross-sectional documentation of body composition changes following SCI. Dr. Cirnigliaro is also a member of the ISCD task force to develop the bone density testing guidelines in persons with SCI, and is currently a member of the committee assigned to write the clinical practice guidelines entitled Bone Health and Osteoporosis Management in Individuals with Spinal Cord Injury, that is being sponsored by the Paralyzed Veterans of America. Hi, Chris. It's great to talk with you today.
Hi.
So I'm really looking forward to your talk because bone loss after spinal cord injury is such a major topic for our viewers and our rewalkers. And so I'm really interested to hear more about your research. For our viewers, we'd love to hear from you as well. So what are some of the recommendations or interventions you employ in practice to help address the issue of bone health for your patients after spinal cord injury? We'd love to hear your thoughts, so don't forget to like and subscribe to this video if you want to hear more talks like this one. With that, Chris, I'm going to let you take it from here.
Thank you for the introduction and for inviting me to speak today at the Topics in Neurorehabilitation series. And today's topic is on bone loss and osteoporosis diagnosis in persons with spinal cord injury. Learning objections are, first, to describe bone loss in patients with spinal cord injury and present original research demonstrating bone loss as a function of time since injury and the utility to predict bone mineral density at the knee region from standardized BMD measurements at the hip. Our second learning objection is to review the use of dual energy X-ray absorptiometry, DEXA, methods to measure BMD of the lower extremities and the currently available guidelines and evidence to diagnose osteoporosis and assess fracture risk. And finally, to briefly describe the rehabilitation interventions that have investigated restoring bone loss in those with chronic spinal cord injury. First, I'd like to provide a definition of immobilization osteoporosis, which is quite different than the definition between primary osteoporosis, where the changes in bone are a result of systemic hormonal changes that occur later in life in both men and women. And the definition of immobilization osteoporosis is a reduction of gravity-related forces on the skeleton and a pattern of bone loss that differs from other secondary osteoporosis because the skeleton above the level of lesion remains largely unaffected, while marked bone loss occurs in the regions that have neurological impairment. The severity of this loss is dependent upon the relative reduction of these forces and length of time these forces are reduced. And this model of osteoporosis is supported by the mechanistat theory, which states that if muscle activity is reduced to such an extent to cause strains within the bones to fall below a minimum effective strain or the bone remodeling threshold, the adaptive process will go into disuse mode and bone tissue will ultimately be lost. So a brief review of pathophysiology of bone loss after spinal cord injury. At the time of spinal cord injury and immobilization, which is unloading of the skeleton, we see an increase in biomarkers of bone resorption and an increase in serum and ionized calcium, as well as urinary calcium. This coincides with a disruption of the parathyroid vitamin D axis during the acute phase of spinal cord injury, which later leads to a decrease in 25-hydroxy vitamin D levels and a decrease in calcium absorption. From the imaging standpoint, we begin to see by DEXA, even during that acute phase, which would be within the first year of injury, a precipitous demineralization or a thinning of the trabecular lattice, followed by into the chronic phase as individuals go into the years after injury, a decrease in the endocortical envelope, which is quantified by cortical bone loss. And this is also measurable, however, not by DEXA. The cortical bone loss and the trabecular bone loss separately are measured by a technology known as computed tomography, but that is beyond the scope of this presentation. Ultimately, this decrease in bone mineral density leads to a high risk for low extremity fragility fracture, primarily at the distal femur and proximal tibia, because this is the first point of impact from most falls from wheelchairs and other activities of daily living. There are several cross-sectional studies that have documented bone loss after spinal cord injury, as well as longitudinal studies that have looked at that change over time, and primarily by DEXA. In a very classic study in 2000 by Doughty et al., looked at 31 patients with chronic SCI greater than 1 year and 31 control able-bodied subjects that were very well matched, and they documented a decrease in BMD of 52% for the distal femur and 70% for the proximal tibia. And most cross-sectional studies show extreme bone loss. However, this tends to be the most extreme documented. However, it's very understood that every study, the cross-sectional study, they see quite a bit of variability in the amount of loss when compared to able-bodied control cohort. Longitudinally, a study by Garland et al. Has shown that the BMD of the distal femur, which was assessed soon after injury with follow-up measurements 4 and 14 months in 12 patients with motor complete spinal cord injury, demonstrate a decrease in BMD of 27% at the distal femur only 4 months after injury, that increased to 32% 14 months after injury. Now, a picture is worth 1,000 words. I think everyone would agree. So we could see here from high resolution computed tomography scanning transverse sections of the tibia bone, all right? And what we see, if you compare the acute and chronic picture, is that the middle section that is very pronounced gray in the acute phase washes out in the chronic phase. And that's both with the tibia, which is the larger bone, and the fibula, which is the smaller bone. Now, we also see that when you compare that image in the same individual from the acute phase 3 months after spinal cord injury to 5 years later, that the outer lining, the endocortical envelope that wraps the bone is also thinner, okay? So it's that endocortical envelope thinning and that cortical bone loss that makes the bones very, very susceptible to fragility fracture. It's also been well documented that bone loss is a function of time since injury. In a classic study by Dr. Esser, using CT technology, it's been documented that time to steady state is between 4 and 6 years, depending upon whether we're looking at trabecular bone at the distal femur, which is the top graph, or the proximal tibia, which is the lower graph. However, there are other models that have demonstrated bone loss can continue in persons with spinal cord injury into over the lifetime, into advanced age. And in a very classic study in 1999 by Dr. Baumann, we see in a monozygotic twin study, that is the graph to the right, that bone loss continued well into 20 and even 30 years after spinal cord injury. And this is an important model because it's discriminated for genetic variability and aging, because what it did was it looked at the interpaired difference scores between the able-bodied non-SCI twin and the SCI twin. So that was is a remarkable study. And there have been other studies by our group recently that have shown if you look at different cohorts cross-sectionally and you are able to look at duration, a very wide spread of duration of injuries, that indeed bone loss can continue into the second decade after injury. And this is a very important clinical note, because the belief by some is that once you hit, these individuals hit 2 to 3 years after injury, that their bone loss is stopped. And now we understand that there's been enough documentation to support Dr. Bauman's twin study findings that it most definitely continues much further than the 2 to 3 year time period. Now, these studies have also shown that at the furthest point, there was between a 30 and 50% loss in BMD, which again coincides with many other studies that have documented cross-sectional decreases in bone mineral density by DEXA. So a brief review of fracture and spinal cord injury. The overall prevalence is between 25 and 46% in the chronic SCI population. Most fractures result from a fall from wheelchair while performing activities of daily living. Fracture-related complications, which would be non-union, infection, pressure wounds, contractures, occur in over 50% of cases. And the risk of having had a fracture increases 4.9 times for each standard deviation decrease in bone density at the distal femur, and 6.1 times for each standard deviation decrease in bone density at the proximal tibia. And that is a prevalent fracture study performed by Lala et al. And this is a very important study that really brings home the risk of fracture for every standard deviation decrease in bone mineral density. And we can also see that from these prevalent fracture studies that overall, the majority of fractures tend to occur at the distal femur and proximal tibia, with the region of the femoral shaft following behind that. So a brief review of bone densitometry by dual energy X-ray absorptiometry. Now, DEXA is very well recognized as the clinical gold standard for measuring bone mineral density. However, it's not a true measure of bone mineral density. What it is bone mineral content, which is validated against ash weight that is an equivalent mass for each DEXA pixel. And then area is calculated for a specific image by multiplying the count of pixels times the pixel size. And ultimately, BMD is calculated by determining the ratio of bone mineral content to a specific area from the DEXA image. But it's very important to understand that aerial BMD is just a proxy for bone strength, and it is not a direct measurement of bone strength. And even more important is that as much progress as we've made assessing bone mineral density and bone imaging measurements, there are no studies whether that have implemented treatment interventions that have looked at ultimately fracture as a primary outcome. So whether it's bone mineral density by DEXA or more advanced imaging methods, the proxy of bone biomarkers is the standard. So the clinical DEXA scans to diagnose osteoporosis are the lumbar spine, the radius 33% region, and the total hip or femoral neck. Now, the lumbar spine L1 to L4 region is very confounded in our spinal cord population, and the radius is not a good site to measure because bone remains relatively unchanged above the level of lesion. So it's not a good indicator of osteoporosis. Now, this is very much in contrary to the primary osteoporosis population. So women, postmenopausal, which is postmenopausal women and men over 50, because what is seen normally as an equivalent amount of bone, regardless of the region measured, right? For the most part, okay, that's on average. However, the one scan, clinical DEXA scan, that we can use in spinal cord injury is the total hip. So in diagnosing that bone loss osteoporosis, the standard at the hip is to utilize T-score from the National Health and Nutrition Examination Survey 3 aerial BMD data. Depending upon which DEXA you have, if you have a hologic DEXA, well, you get that reference database directly. However, if you use a GE Lunar DEXA, all right, which are the two largest DEXA manufacturers, what it is a modified NHANES database where GE Lunar combines the company-specific normative data with the NHANES national reference database. But in either case, the Osteoporosis World Health Organization and International Society for Clinical Densitometry criteria is a T-score less than or equal to 2.5 standard deviations below the mean at the lumbar spine, proximal femur, and 33% forearm region. Now, the reason why it's important to understand that is that much of the literature cites BMD values of about 0.6 as being the fracture threshold region and or the diagnostic threshold number to exclude individuals from ambulatory activities that have a spinal cord injury. Well, that work, as you will see, was originally presented by Dr. Garland, and it was also kind of accepted because that number of 0.6 is this obviously the same number, as you could see, where in the primary osteoporosis population, a T-score of negative 2.5 standard deviations at the hip occurs. So this has been very much embraced right now as kind of being this cutoff where we do not allow individuals with spinal cord injury to move forward with advanced ambulatory activities like exoskeleton assisted walking. So if hip T-score is a valid measurement, and hip bone mineral density a valid measurement, then why not just use that to diagnose osteoporosis and spinal cord injury? Because it is below the level of lesion. So another publication from our group recently, published in 2000, looked at the relationship between hip T-score and aerial BMD at the distal femur and proximal tibia utilizing DEXA. So if they were equivalent and you could use the hip values to say somebody's at a high risk of fracture at the knee, then you should see an amazing correlation. And on the contrary, in about 105 individuals with spinal cord injury, we get more of a moderate correlation, all right? However, if we don't look at correlation and we look at agreement through a Bland-Altman analysis, we see that there's many points outside of what we would call the clinical and statistical limits of agreement. So, you know, the work should not be done, should not stop there. Direct measurements of the distal femur and proximal tibia, just from understanding that the hip does not account for all the variants in that model, are definitely necessary. So here's some images of the distal femur and proximal tibia of the knee region. The image to your right is a CT image of the knee in which the regions of the distal femur metaphyses and the proximal tibia metaphyses have been validated against CT scan. And it's a very strong validation. And then the image to the left is essentially the one of the investigator-driven region of interest and methods that we utilize to capture the BMD that we call the distal femur and the BMD we call the proximal tibia. Now, that protocol has been well detailed in the papers that I just described, and some additional papers that I'll cover if anybody is curious. So cutoff BMD values, the fracture threshold values at the distal femur and proximal tibia. So this work by Garland that I mentioned earlier established that the aerial BMD cutoff criteria of 0.6, and it should be from a very large prevalent fracture study that Garland had done, probably one of the largest to date, be utilized to understand that this is where the BMD, where most individuals are at very high risk for fragility fracture. So since this time, that BMD value of 0.6 and more of the corresponding BMD value or T-score value of negative 3.5 standard deviations as the total hip have been utilized to exclude individuals from advanced ambulatory strategies, not just exoskeleton assisted walking, but also other interventions such as neuromuscular electrical stimulation, FES cycling, and this has been kind of the standard so far. If you look at most studies, the IACD task force position paper on bone densitometry and SCI covers this well, as well as this new consortium clinical practice guidelines on bone health and spinal cord injury. Now, there are deviations from that. Some studies have used slightly different numbers, but they're all in this range. However, none of these studies have been what we call incident fracture studies, where we followed individuals over time to document the BMD at the time of fracture. They've all been just cross-sectional studies where they scan lots of people and then they take a fracture and no fracture group and they say, okay, this is what the BMD was in the fracture group. And in many of these studies, it's been about 0.6. However, because there are no incident fracture studies, these recent 2019 IACD guidelines have established that there's no threshold BMD value below which weight-bearing activities are absolutely contraindicated. BMD and clinical risk factors should be used to assess fracture risk prior to engaging in weight-bearing activities. So the answer to should we exclude individuals, if you go by the IACD guidelines, is no. Individuals shouldn't be excluded. However, there's a lot of controversy. Many investigators in trials just continue to utilize some BMD criteria just because they want to have something in place to eliminate those at the highest risk for fracture. So there's two different things going on right now at the same time. In the largest powered exoskeleton assisted walking randomized control trial by Dr. Ann Spungen, sponsored by the Department of Veterans Affairs Cooperative Studies, a nationwide randomized control trial investigating the use of exoskeleton assisted walking in the home and community has recently been completed. From this work, a protocol was published in 2020. From these individuals that were screened for participation, the largest exclusion criteria that kept individuals from participating was a knee aerial BMD of less than 0.6 grams per squared centimeter. And even though this criteria lacks evidence as exclusion criteria to avoid fragility fracture, it did allow Dr. Spungen and the study team to proceed without the occurrence of any lower extremity fragility fractures. So from the total number of individuals screened, a cohort of 142 participants were randomized into the study. However, from that larger group that were screened, almost 27% who were consented for screening and almost 55% of all screen failures had failed entrance criteria due to a history of fracture or aerial BMD below the defined criteria of 0.6 grams per squared centimeter at the distal femur or proximal tibia, or a T-score of less than or equal to negative 3.5 standard deviations at the total hip. So the limitation of fracture threshold studies, cutoff values obtained from smaller number of fracture cases in all of these studies. They're all prevalent fracture data. Insulin fracture studies are needed to really understand bone mineral density values that occur at the time of fracture. And aerial BMD values are quite dependent on the different DEXA manufacturers and the BMD values where BMD was measured, right? So the site where BMD is obtained. The next limitation to many of these fracture threshold studies is that normative aerial BMD values at the distal femur and proximal tibia from these manufacturers are not available. So when you see a BMD of 0.55 or 0.6, many times the question that our research unit gets from physical therapists and from clinicians is, well, what does that mean compared to someone without a spinal cord injury, right? That is the same gender, same sex, same ethnicity potentially. And the answer is that we don't know. So that makes the use of these absolute BMD values really, really less than perfect. And again, the reason why is that there's no manufacturer normative BMD values available. So there's nothing like a population specific NHANES database with BMD at the knee, normative BMD values at the distal femur and proximal tibia. However, investigator-derived normative BMD values are available. So some groups, specifically the Toronto Rehab protocol, that would be Dr. Kathy Cravens, has not just a normative BMD database, but it's Z and T-score calculator that is available on the link below provided, as well as in that ISCD 2019 position paper. And more recently, our group has out for publication normative BMD values at distal femur and proximal tibia that we've collected. So we're making quite a bit of progress there, but using just BMD values is definitely a limitation to using any fracture thresholds. So quantifying precision error from densitometry, the least significant change, is a very important metric to understand, and it's recommended by the ISCD that the precision error calculated as the root mean square coefficient of variation is utilized with a 95% confidence interval, which is a multiplier of 2.77 to obtain the least significant change. And ultimately, it is the number that allows you to understand that greater than this variability accounts or within this variability there. Well, can I do this slide over? Let me take a breath. So quantifying precision error from densitometry, the least significant change is the standard metric that is recommended by the ISCD, and it is calculated as the precision error, which is the root mean square coefficient of variation, multiplied by the 95% confidence interval, which is 2.77. And this least significant change accounts for the non-biological change in soft tissue and bone from densitometry, which can be caused from instrumentation, technician, positioning, patient hydration, and multiple other variables. So it's the variability that's accepted before you understand that anything outside of those numbers, as far as a percent change over time from a treatment intervention, is true biological change. And like I said, least significant change is the least amount of BMD change that can be considered statistically significant, and it must be calculated when performing densitometry in the SCI population. So interventions with DEXA as an outcome in the context of XCI, treatment effectiveness should be defined as stability or an increase in absolute BMD at the anatomical site, which is equal to or greater than the least significant change for all of the regions that we covered. However, to date, there are a few studies with level 1 evidence obtained from at least one randomized control trial demonstrating the therapeutic efficacy of individuals with chronic SCI with low bone mass. And none of these studies have evaluated fracture risk as an fracture risk reduction as an outcome. So here's a small list of studies that have used rehabilitation interventions to reverse bone loss in what you would call an early chronic population, all greater than 1 year, but in all 4 studies, less than 2 years from their time since injury. The top study by Belanger utilized neuromuscular electrical stimulation, which is electrical stimulation against gravity. And a change in BMD was noted at or a decrease in BMD was noted at the distal femur and proximal tibia of both legs. However, the additional 3 studies utilized functional electrical stimulation cycling to try and reverse bone loss at the distal femur and proximal tibia. And all studies were successful at seeing increases in BMD. However, the thing that they all had in common was that the training interventions were much higher than clinically normal, were much more intense than is done clinically, with a frequency of training and a duration of training that was much greater than most people would be able to do in the clinic. In addition, once training was discontinued, most of the gains were lost at the distal femur and proximal tibia. So even though rehab definitely, at least these rehabilitation strategies, has an effect on bone, their actual generalizability is somewhat limited due to the intensity and the fact that most gains are lost once training stops. And I have provided references that were cited throughout the presentation. And thank you so much for your time. And I'm available by email if you have any questions about this presentation.
Thank you, Chris, for such a great overview of an incredibly important topic. I know there's a lot more material that you didn't have a chance to cover, and so I'm sure our viewers will want to learn some more. So to that end, I prepared a few follow-up questions for you. So the first one we have is, I think one of my biggest takeaways from your talk is really related to the importance of being able to accurately evaluate and track an individual's bone health over the course of time. How frequently do you recommend patients get follow-up bone scans after their initial injury?
So the IACD guidelines covered that, and it's pretty simple. And what it states is that an initial scan, a baseline scan, should be done as soon as medically stable during the acute phase, right? And I think that is a very broad guideline because it takes into account the logistical barriers of getting a DEXA scan in the clinical environment, and then follow-up DEXA scans to be done 1 to 2 years as needed, right? Because there may be some variability in the interventions that somebody is getting. Somebody may be receiving a functional electrical stimulation in the clinic with FES cycling, or they may be doing that rehab at home, or they may, you may have other reasons to think that they are at a higher risk for fragility fracture. For example, we do know that a lot of young individuals we see, individuals that are, that have never achieved a peak bone mass, can get into that fracture threshold relatively quick. So if you think that somebody has a lot of other risk factors for bone loss and has been really immobilized even further from normal activities due to pressure ulcers, and they have some of those risk factors such as fragility, and they have a family history, the physician may want to see DEXA scans done every year instead of every 2 years.
That makes sense. Interesting point that you made too about younger individuals potentially not having yet reached their peak density prior to their injury. I think that is potentially something that goes without people sort of considering sometimes. So that's really great to keep that in our minds as well. So a little bit more about the DEXA scan. So you discussed how that is really just a proxy for aerial BMD. So what, for a clinician, does this mean in terms of how they should interpret DEXA scan results?
Well, so what I meant is that DEXA is a proxy for bone strength, right? So it's about 50 to 80% of bone strength can be accounted for, of the variance in bone strength can be accounted for by BMD, right? So the other things that make up a huge amount of that variance, depending upon an individual, is bone shape, right? So bone geometry. And then there is the material structure of bone, all right? And again, this is why more advanced imaging can now account for more variance in the fracture threshold modeling. So CT imaging can now allow you to understand bone strength much better, because it not only takes into account density, it takes into account geometry. And now there's even more elaborate mechanical model, I apologize, engineering models known as finite element modeling that can account for all of the factors of bone strength. And these are computerized models that look at all of these factors that I mentioned, of density and geometry, plus forces, potential forces that happen around the joint. And it's a very elaborate model. It's something that is being done in research for quite a long time in the able-bodied population, with a few groups doing it at SCI, and now our group at the VA doing it with researchers at NJIT, as well as other engineering groups at the Kessler Foundation. So, that is something that we're doing as well. But like I said, all of these metrics from looking at for looking at a change in bone from an intervention in the primary osteoporosis population, they have them and fracture, right? So in these large pharmaceutical sponsored studies where they're looking at specific drugs, they're not just looking at changes in bone biomarkers. They're looking at the group that got treatment fracture less than the group that got no treatment. Okay. Yeah. And, here's the thing. We just don't have the sample size, right, to do that in any of our studies. So these proxies are kind of the standard for the research that we do.
That's really helpful. Definitely helps to sort of like wrap your head around a little bit more what it is that we're looking at when we see those numbers. I think we all recognize the numbers, but that was super helpful in helping to understand what it is that we're really looking at there. All right, a couple more for you, because this topic is just so much more deeper, I think, once you get started talking about it, obviously, as you know, doing the research on it. For the therapists in our audience, I know they'll be interested in the rehab bit and interventions that can potentially provide some help to slow or reverse the rates of bone loss after SCI. So for those studies that you reviewed about the rehab interventions, it was definitely interesting that the benefits were not durable beyond the end of the intervention. So can you talk a bit more about this maybe, and how it perhaps informs the way that we should think about advocating for home equipments for patients' long-term use of this type of intervention? Yes,
so that's a great question. So as you saw from those rehab interventions, it's not that all the gains are lost, it's that most of the gains are lost. So the promising thing about that is that in a majority of those studies, those gains, some of those gains were kept because they didn't get rid of the training intervention completely. They just reduced the frequency and time of training. So instead of 5 days a week, many of these individuals went to 2 or 3 days a week. So even though they saw a loss of some of the gains, right, there were still, right, gains. So, I mean, that's kind of, a half glass full scenario. And if you want to look at it as half full, at least you could take an individual that maybe was getting a more intense regimen, right, in the clinic, in acute rehab, during outpatient, and now advocate for a Regis, an RT bike rather, all right, for FES cycling, especially if they look like they're at a very high risk for fracture. And more importantly, is if a DEXA scan starts to get done in the future within those first 6 months after injury, you can see where that person's going. And that's even more advocacy to, justify. I mean, we're seeing more and more people buying RT bikes for home use. 20 years ago, it didn't exist. Now it's, I mean, there's more doctors fighting for that, obviously for other reasons, right? For muscle and circulation and all of these other reasons, and potentially function. But I think that, as insurance starts to pay for that more and more, incorporating the risk of fragility fracture and how, this can help mitigate some of that loss and keep their bones as strong as possible is an important thing, that point that physicians can make.
Absolutely. And a little plug from our end, there's another product, the MyoCycle from Myelin is actually another similar product to the RT. So there's a few different ones on the market now. So I definitely agree to your point that more and more we're sort of like recognizing that long-term benefit. So it's really exciting to see some numbers and data coming to support it, because as we all know, that's what ultimately the reimbursers and everybody wants to see. So
Sure.
kudos to you for bringing that to light. So the last thing we just have is any other resources that you wanted to chat about, things that you'd recommend for any of our viewers who are interested in learning more about bone health after spinal cord injury, or any of the topics that you presented today.
Absolutely. And that would be the ISCD 2019 guidelines from Dr. Morse, who is a leading expert in this field, as well as the PVA clinical practice guidelines on bone health. We're finishing the final edits of that, and that should go into production this summer. It's the largest clinical practice guidelines the PVA has ever put out. And it covers every area of bone health you could think, and it should be available in the fall. So I think, and along with the other references, I think that those two documents really cover so well. And it's just been an honor to be a part of them, bone health and spinal cord injury.
That's excellent. I love your enthusiasm. Thank you so much for a great talk, and thank you for your time as well.
It's my pleasure. Thank you.
And to our viewers, we hope that you've been finding these talks interesting and helpful. Don't forget to reach out in the comments section or via our contact us page to tell us how you address issues related to the bone health of your patients. Please also make sure to like and subscribe using the buttons below, and feel free to use the comments section to suggest future talks and topics. We hope you tune in again with us next episode. Take care, everyone.